a patient in a lower acuity area um, is often under monitored. And by under monitoring, I mean there is a decrease in patient to nurse ratios compared to high acuity areas. There is also intermittent checks on blood pressure and intermittent checks on the patient's mentation, respiratory rate, urine output, and so on and so forth. All this means that there is a lot of underdiagnosed hemodynamic fluctuation. These patients are at risk of prolonged periods of hemodynamic instability. Some of the research that I have done does show that, for example, postoperative hypotension is extremely common in lower acuity areas as well. So, as a direct extension of that, we do know that cardiac output, for example, is an important indicator of the overall perfusion and flow dynamics that an organ is receiving. There are situations where blood pressure might be totally okay and cardiac output may be suffering. The patient may be relatively asymptomatic, but there is ongoing organ system injury because of that derangement in cardiac output that's coming on in a subtle way. There may be other situations where a patient is on the verge of or is experiencing some arrhythmias that are going unnoticed. Furthermore, there may be situations where the patient is receiving lots and lots of fluid, but we're not really understanding how much fluid a patient should receive because we don't have invasive hemodynamic monitors. So to put it all together, that really um, tells us that we should be doing more. We should be doing more with less. So largely speaking, patients in the intensive care, that's the only time when we're trying to focus on fluids, inotropes, cardiac output, blood pressure, all put together. As soon as the patient leaves the ICU, all of that is done. That should not be the case. We should still focus on a continuum of care for that patient, because just because the patient has left the four walls of the ICU doesn't mean that there is perfect hemodynamic stability.